Avoidant/restrictive food intake disorder, commonly known as ARFID, represents one of the most misunderstood eating disorders in contemporary mental health literature. Unlike the more widely recognized anorexia nervosa or bulimia nervosa, ARFID is characterized by persistent failure to meet appropriate nutritional and energy needs, leading to significant weight loss, nutritional deficiency, dependence on enteral feeding or oral nutritional supplements, and marked interference with psychosocial functioning. This condition affects individuals across all age groups, though it is particularly prevalent among children and adolescents, often emerging during early childhood when eating patterns are still developing. The complexity of avoidant/restrictive food intake disorder lies in its multifaceted presentation and diverse underlying mechanisms. Individuals with ARFID may exhibit extreme food selectivity based on texture, appearance, smell, taste, temperature, or brand preferences. Some patients demonstrate hypersensitivity to sensory aspects of food, making eating an overwhelming and distressing experience. Others may have experienced negative associations with eating, such as choking incidents, vomiting episodes, or allergic reactions, which subsequently trigger avoidance behaviors. Additionally, some individuals with ARFID show apparent lack of interest in food or eating altogether, consuming insufficient quantities to maintain healthy body weight and proper nutrition. The diagnostic criteria for avoidant/restrictive food intake disorder have evolved significantly since its inclusion in the Diagnostic and Statistical Manual of Mental Disorders, 5th edition. The disorder must result in clinically significant weight loss, nutritional deficiency, dependence on nutritional supplements, or psychosocial impairment. Importantly, the eating disturbance cannot be better explained by lack of available food, cultural practices, concurrent medical conditions, or other mental disorders. This distinction is crucial because many individuals, particularly children, may exhibit picky eating behaviors that do not rise to the level of clinical significance required for ARFID diagnosis. Research indicates that avoidant/restrictive food intake disorder frequently co-occurs with other psychiatric and developmental conditions. Autism spectrum disorders, attention deficit hyperactivity disorder, anxiety disorders, and obsessive-compulsive disorder are commonly associated with ARFID. Individuals with autism may demonstrate rigid food preferences and sensory sensitivities that contribute to restrictive eating patterns. Those with anxiety disorders might develop fear-based avoidance of certain foods or eating situations. The intersection of these conditions creates complex clinical presentations that require comprehensive, individualized treatment approaches. The impact of avoidant/restrictive food intake disorder extends far beyond nutritional concerns, affecting multiple domains of functioning. Children with ARFID may struggle with social situations involving food, such as birthday parties, school lunch periods, or family gatherings. These challenges can lead to social isolation, academic difficulties, and strained family relationships. Parents often report feeling frustrated, helpless, and concerned about their child's health and development. The disorder can create significant stress within family systems, particularly when mealtimes become battlegrounds characterized by anxiety, negotiation, and conflict. Treatment approaches for avoidant/restrictive food intake disorder typically involve multidisciplinary teams including mental health professionals, registered dietitians, and medical providers. Cognitive behavioral therapy has shown promise in addressing the thoughts, feelings, and behaviors associated with food avoidance. Family-based interventions are particularly important when treating children and adolescents, as parents play crucial roles in creating supportive eating environments and implementing treatment strategies. Exposure-based therapies gradually introduce feared or avoided foods in systematic, supportive ways, helping individuals develop tolerance and acceptance of previously rejected foods. Nutritional rehabilitation is a critical component of ARFID treatment, often requiring creative approaches to ensure adequate caloric and nutrient intake. Registered dietitians work closely with patients and families to identify acceptable foods, expand dietary variety, and address nutritional deficiencies. In severe cases, medical monitoring may be necessary to assess for complications related to malnutrition, including cardiovascular, gastrointestinal, and metabolic concerns. Some individuals may require temporary nutritional supplementation or, in extreme cases, enteral feeding to stabilize their medical condition. The prognosis for avoidant/restrictive food intake disorder varies considerably depending on factors such as age of onset, severity of symptoms, presence of co-occurring conditions, and access to appropriate treatment. Early intervention generally leads to better outcomes, emphasizing the importance of recognizing and addressing ARFID symptoms promptly. With comprehensive treatment, many individuals can expand their dietary repertoires, improve their nutritional status, and reduce the psychosocial impairment associated with their eating difficulties. Understanding avoidant/restrictive food intake disorder requires recognition of its complexity and individualized nature. Each person with ARFID presents with unique patterns of food avoidance, underlying mechanisms, and treatment needs. As awareness of this condition continues to grow among healthcare providers, educators, and families, more individuals can receive appropriate diagnosis and evidence-based treatment. Continued research into the causes, mechanisms, and treatment approaches for ARFID will undoubtedly improve outcomes for those affected by this challenging but treatable eating disorder.